Hello, and welcome to the virtual version of Transgender-Affirmative Care, Identifying and Overcoming Barriers to Care for Transgender Patients. So my name is Oak Reed, and I'll be providing this training for you. I apologize for not being able to be in person. I imagine most of us would agree that we'd love to be socially connecting now, but for safety reasons, I'm going to be delivering this from afar. A little bit about myself is that I am from Michigan. I went to Central Michigan University to get a bachelor's degree in psychology and sociology. And right after graduating college, I moved to Missoula, Montana to pursue a PhD in clinical psychology. So out there, I've gotten my master's degree in clinical psych and have conducted quite a bit of research on transgender issues and other kind of minority cultures on the way to getting my PhD. And where we're at now is working on my dissertation, which is this training. So all of you have participated in the pre-survey component asking about experiences with trans individuals and your level of education on topics regarding trans care so far. And that's what my dissertation is understanding that level of training, the interaction that folks have had with trans individuals, both personally and through educational realms and so on, and then seeing if we can improve that. And so that's where I'm at now, is working on my dissertation, and I'm 1 year shy from my PhD in clinical psych. I will be doing my predoctoral residency at the Milwaukee Veterans Affairs Medical Center next year, and hope to continue pursuing this line of research. So let's just jump right in. Here's the slide that's a little bit about me. So I want to talk about who is a trans affirmative provider, because I think that's an important question to start with. And I think that all of us can be a transformative provider at the end of this, 50 to hour minute training. First things first, those who are affirmative providers are, of course, educated on what it means to be trans, educated on those identities. Because you need to know the identities in order to be aware of the barriers to care and in order to be able to remove those barriers or at the least reduce them. In order to remove them or reduce them, well, we have to be conscientious of how we can create a welcoming environment. What does a welcoming environment look like, and how can we modify our work environments to make them as welcoming as possible? Many times, trans individuals don't have advocates, and they are their own advocate. And in some cases, they may have advocates such as family or close friends, but oftentimes, the healthcare providers might be their number one advocate. So we need to advocate for excellent physical and mental health services for these individuals, especially in a realm, in the healthcare realm, where they have been historically treated not so well. And lastly, I think we need to collaborate with an interdisciplinary team to achieve holistic care. When we're working together and understand what each other's role is in affirming a trans individual and helping facilitate their experience through the healthcare realm, then we're doing our due diligence to those folks. So I'm going to talk about how we can achieve each of these steps through this training so that all of us can be and label ourselves as trans affirmative providers by the end. Here's my general outline. I kind of think about this training as broken into two parts, talking about some of the important 101 regarding trans identities, and then talking about some of the history and contemporary statistics regarding what it means to be trans and when people typically realize that, the barriers that they face, some statistics around health disparities. And then I'll shift gears and saying, well, what can we do about that? How can we implement strategies to create a welcoming environment? And what are some things that you, as a viewer, can do when we all return back to work to make those places as affirmative, welcoming, and safe as possible? I can't answer questions at any point as I normally would, but of course, feel free to email me at any point if you have any questions or need some clarification. I'd be more than happy to provide a response for you. Here's my learning objectives, and with this, I want to say that I am happy to share my slide deck with anyone who is interested. So again, just email me, and I will send that out. So let's start with important terminology. These three terms are things that we use interchangeably, and we use them often all the time, but many times we end up using them inappropriately. So I just want to spend some time clarifying. So sex is a term that is based on our internal and external anatomy. So internal and external genitalia largely is dictated by our chromosomal composition and often is influenced by the hormones that we have that are dominant within our body. Now, it's not to say that that's the only description that we can put with sex, because there are some differences outside of the binary sex of male and female. So for example, we might find an individual who has internal genitalia of ovaries and a uterus, but external genitalia of a micropenis. Or vice versa, we might have testes, but externally a vagina. We might also see abnormal chromosomal compositions like XXY or XXX, and we categorize those often as intersex or things just simply outside of the binary of the sex that we assign at birth. And of course, we see differences in concentrations of hormones across the lifespan, but also within little infants that are born. So, sex is a little bit more hardwired when we look at it objectively and through the biological lens. But I want to just share with you that it's not always as hard and fast as that. It's not as black and white as sometimes we think. But needless to say, we need to remember that sex is something that is more biologically driven. And the way that I kind of jokingly think about it is that sex is often between the legs. And that's just a silly mnemonic to remember the difference between that compared to gender. Whereas gender is something that is mentally defined, and only an individual can define that for themselves. So people will identify as male, female, trans male, trans female, agender, bigender. They might identify as so many different genders, and the lexicon regarding gender identification is only growing. So, importantly, in the kind of paired mnemonic for this is that whereas sex is between the legs, gender we can think of as being between the ears or within our mind, and only an individual can define that for themselves. That, as I'm talking, probably it screams not black and white because it definitely isn't just as much as sex. It is much more of a continuum than the binary. However, we often superimpose the binary of male and female on the categories of sex and gender. But the most important takeaway, too, is that sex and gender are uniquely different terminologies and need to be used differently to gather the information that is relevant to us at the time. Different from sex and gender is sexuality. Sexuality, as simply put as possible, is who we're attracted to. And the mnemonic to kind of pair with between the legs, between the ears, is within the heart. Now, sexuality is much more multifaceted, and I will get to that. But I just wanted to pause here and remind us that sex, gender, and sexuality are uniquely different entities and should not be used interchangeably. It can be important for us to ask about sex assigned at birth first, because that gives us information about a person's anatomy and can give us then information that information can lead us to giving specific healthcare advice on how to appropriately care for their body. When we're asking about gender identity as the next kind of step in the process, that can give us information of who is that person, what are they all about, and what are some of their values, some of the things that are important to them, and that can also lead us to appropriately inform our healthcare decisions and our interactions with them. And then asking about sexuality, if it's relevant to our healthcare that we're delivering for them, that can give us information to perhaps who they're partnered with and what type of advice we would maybe need to give to them for that. So the question might be well, what does it mean to identify as transgender? As simply put as possible, and this isn't the only way to describe it, but just to distill it to some simple basic differences, is that when someone identifies as transgender, simply put, their sex and gender do not match. The sex that they were assigned at birth does not match their current gender identification. I emphasize current gender identification because gender is fluid, not only in the terminology itself, but also sometimes across the lifespans for some individuals. So it's a question that we can't just ask once and leave it at that. We often need to get updates from our patients to ask, what is your current gender identification if we haven't seen them for quite some time? And this needs to be a consistent thing that we're asking across all individuals, not just those that we presume to be transgender. Another term that's important to know is cisgender. Cisgender, again, as simply put as possible, is when an individual's sex assigned at birth does match with their current gender identification. So we see the term cisgender and transgender often in the literature, but it is an important question or term to know and to use in your healthcare practice because it can help normalize the use of these terms and give quick demographic descriptors of our patients as we're doing our rounds in the morning or communicating demographic information to a colleague or so on and so forth. I alluded to the fact that sexual orientation was quite multifaceted, and although this training isn't about sexual orientation and best care practices for sexual minority individuals, it is important to note because transgender individuals are also often sexual beings. A lot of trans individuals do indeed have a sexual orientation, and they may engage in different sexual acts. So we need to perhaps ask this if it's relevant to our care for them. So, sexual identity is simply the labels that an individual uses for themselves, whether that be bisexual, heterosexual, non heterosexual, gay, lesbian, pansexual, you name it. Again, it's the lexicon is growing. But those are the identities that are the label that the person identifies with and feels comfortable with. The behavior is the sexual intercourse that they're engaging in, whether that be men having sex with men, women having sex with women, men having sex with women, penile vaginal intercourse, penile anal intercourse, vaginal intercourse, you name it. Those are the sexual behaviors that an individual is engaging with. It's important to ask these in a stepped process as well, because just because someone identifies, let's say, as heterosexual, doesn't mean they are exclusively engaging in traditional, and I would put air quotes around that, heterosexual intercourse. That could look quite different for an individual, but maybe they don't want to shift their label or don't feel comfortable with a different label. So we need to ask those questions, their identity, labels, and then the behaviors they're engaging with, again, to appropriately inform the healthcare practices that we're engaging with those folks. And then lastly, the attraction is simply as it sounds, those are who we're attracted to. And we all have unique attractions across our lifespan that might not be relevant to our identity labels and might not be relevant to the behavior, but they might ebb and flow throughout time as we grow and understand ourselves. So number one question I get is, well, okay, I'm understanding the terms. I can understand what it means to be transgender versus cisgender and how that's different from sexuality, but what is the likelihood that I'm going to encounter a trans individual and how young might they be? Well, the developmental literature for decades upon decades has said that gender identity onsets around the age of 3 to 4. And that's not exclusively research looking at trans individuals, that's looking at just any child, period. That gender identity and the realization of that and the understanding and recognition of gender happens pretty darn young. So, therefore, the answer is you're going to find these people pretty darn young, especially as our culture shifts and becomes more accepting and affirmative towards talking about this. Kiddos are going to be more confident to share their gender identity differences at a very young age. And then the question is, well, how prevalent is this? And this statistic that I have on the slide is from a meta-analysis that the American Journal of Public Health published in 2017, I believe, saying that roughly 1 in 250 adults, or around 1 million Americans, will identify as trans. So, a significant amount. But I think that this is a gross underestimation of the actual prevalence of trans individuals in America. The reason being is that although certain questionnaires might ask about gender identity, not often do they separate from that two-step method that I was mentioning of asking sex assigned at birth and current gender identification. So therefore, the surveys might not be explicit in saying, I want to know the whole of you, not just parts of you. People might be confused of what should they disclose? What is this questionnaire actually asking? Is it safe for me to disclose of my trans identity, even if the survey says that it's going to be anonymous? It's a lot of questions that run through trans individuals' minds that lead them to maybe not always disclosing their trans identification. So therefore, because of all those reasons, I think that it actually may be much more prevalent than we presume, and it is much more likely that you're going to encounter a trans individual if you haven't already. So therefore, we need to be prepared. I have some pictures of some little kiddos on this slide purposefully because I imagine as I'm talking, people might have been gazing at them and subconsciously lumping them perhaps into some type of sex category, because that's often what we do. Is that baby a boy or a girl? That's the first question that we ask pregnant women of, are you having a boy or a girl? We have these gender reveal parties, which actually is an inappropriate use of the term because they indeed are sex reveal parties. One of the best responses I ever got when I slipped up and asked a colleague, are you going to have a gender reveal party? Are you going to know the gender of your baby? Coming from a person who does this research day in and day out, I even make mistakes, which says it's okay if you make a mistake too. But her response was so elegant and appropriate, and she said, we're actually not going to know the gender of our baby until they're able to disclose of that to us. But yes, we do know the sex of our baby, and it's going to be a so on. I thought that was a really brilliant and wonderful response, and a way to remind me it's okay to slip up, but we can each gently remind each other to use these terms appropriately. But nonetheless, I imagine that our natural inclination is to lump these babies into different categories, looking for cues to say, what is this baby? And you might see the top one in the pool is topless, in a blue pool as opposed to a pink pool, hanging out with a dog, historically man's best friend. So maybe that's a little baby boy. And the bottom, well, that one's topless too, but who knows? Babies are topless all the time, but looks like a little bit longer hair, pushing a shopping cart, which is, typically stereotyped as a feminine toy, but in the cart is Barney and not Baby Bop, so perhaps this one's a little bit more confusing. And so why I put these here and why I use this exercise is to remind us to slow that process down. Try not to lump individuals into categories and rather allow them to share tidbits of information about themselves so that they can disclose to you parts of their identity that are important to them and parts of their identity that they want you to know. But to resolve the mystery of this, both these babies are me. Can you see the resemblance here? But anywho, I wanted to remind you to slow that process down, but also know that this concept of gender dysphoria, which is the new DSM-5 categorization, gender dysphoria meaning discomfort within one's gender that they currently identify with, when that feeling persists through the onset of puberty and within puberty, if that is something that is omnipresent, it's unlikely to go away. It's unlikely to desist. So when kiddos are persistent, consistent, and insistent about the fact that they don't feel right, we need to listen very critically to that because it's unlikely to go away. So we need to understand these barriers to care for kiddos and adults across the lifespan in order to overcome them, because they don't necessarily feel like the rolling sand dunes along Lake Michigan. They feel like the striking big mountains in Montana. They feel overwhelming. They feel daunting. They feel impossible. And those are adjectives that trans individuals often use when they talk about navigating the healthcare system. So we need to reduce that and make it more accessible for them. So 2 resources that I want to share with you. The first one is the Movement Advancement Project. That's where this map is coming from. Although looking at maps right now might feel overwhelming because we've been looking at a lot of them in the coronavirus era, but I want to share this with you because it gives a really good snapshot of how we're doing as a country regarding having policies in place to protect trans individuals. So as a country at large, we're still not doing so hot. And the map here, and why I love the Movement Advancement Project, is because they update this map as often as they can. And if you go on their website, you can actually click state by state, and at times county by county if they have any specific county relevant policies that they have stumbled upon. So you can go into where you're working at, what state you're working at, and perhaps what county, and see how you're doing and where you can make changes at a local level. But it just gives us a picture to say we're not doing so hot, but we're making progress, and that gives me hope to show that we can make progress and make this more of a light green map, or dark green map where they have high protective policies as opposed to the dominant red. Another resource that is really phenomenal is the National Transgender Non-Discrimination or Discrimination Survey. This survey has been conducted twice. First time, they only had about 7,000 respondents in 2008 and 2009. In 2015, they had nearly 28,000 respondents. I point that out because that too gives me hope that several years ago, almost a decade ago, or over a decade ago, excuse me, there wasn't as many respondents. But as time went on and those positive protective policies came into place and healthcare workers were reaching out more, saying, I want to work with you, I want to be affirmative towards you. That made trans individuals feel safer enough that many more of them came to this survey to say, I want to share my experiences to improve it for my fellow trans individuals. So that gave me so much hope to see this number grow. And as they collect data right now, I hope it continues to grow so we understand it more and more on an intimate level. This survey is extremely comprehensive in talking about discrimination across any categorization you can think of, from discrimination in housing, in the workplace, in religious institutions, in relationships, whether it's romantic or familial or platonic, and so on. What I'm going to talk about mostly today is the section on disparities in health and healthcare. I so encourage you to go click around in this survey. It is well written and well laid out to really understand the nuances of discrimination that this population faces. But we're going to focus in on disparities in health and healthcare. I will break out into a lot of these individually. One that I don't have a specific slide, but I want to mention is number 3, the conversion therapy and other pressures to detransition. Now, conversion therapy is kind of a thing in the mental health field that we're not very proud of because there is no evidence saying that it in fact is helpful. I'm going to show this. There's no evidence that actually shows that it's helpful. In fact, APA has put out statements saying that we have evidence showing the opposite, that has been very detrimental. Conversion therapy was originally developed in the context of sexual minority treatment, trying to convert them from having their non-heterosexual sexual desires. So essentially what they did was have these non-heterosexual individuals come into therapy, watch gay pornography or same-sex pornography while taking a pill or some type of thing that would make them feel nauseous. So over time, that conditioning process of watching same-sex relationships with that pill that would cause aversion and nausea, that would be paired so that they'd begin to feel aversive and nauseous towards their own sexual thoughts to have same-sex intercourse or same-sex attractions, therefore, quote-unquote, converting them. We found that that didn't actually work. We didn't convert or change anything. We just essentially conditioned them to feel hesitant about that and so on. So they've done that in the context of trans individuals as well by trying to do conversion therapy to change the thoughts that they are identifying with the opposite sex. And we found that that doesn't actually work. There's a lot of pressure, external pressures to detransition or to transition away from identifying as trans. And what we find is that often it only works temporarily, if at all. People may kind of follow through with things and detransition, stop taking their hormones, stop using the name that they actually prefer, only really to feel safe in maybe their setting. Maybe their parents or family gave them an ultimatum, either you detransition or we're not going to interact with you. But oftentimes in this survey has said that once they felt safe and comfortable within themselves, they often transition back to some degree. Another caveat I'll throw out there too is that a lot of people decide to transition to a certain degree. Some people will want to physically transition their entire body. Some people may not want to physically transition at all. So that is a number one thing to keep in mind too, that not every individual wants to transition in a way that we would maybe kind of conventionally think about transitioning. But let's jump into some of these other areas. So when I think about routine and transition-related health and healthcare coverage, first you have to think about health insurance. Think about the access of health insurance that these individuals have. Most of us have access to health insurance through our employment, through our spouse, or through government aid. So we have to think about, well, if there's discrimination in other areas of life, like securing a job, through having relationships and so on, well, perhaps their access is already limited and they may not have health insurance. But let's say they do have access, and we have to think about, well, what is the source and the coverage from that source? Is it private or public? What state do they live in, and what policies regarding coverage are put in place to cover transition-related care, or is it lumped as cosmetic, non-necessary care? So we have to be really critical to think, well, just because they have health insurance doesn't mean they're necessarily well off in securing the financial support that they need to pursue any degree of a transition. So then when we think about routine care, we have to think about several things like the outness, the level of outness. Are they out to their provider? What type of health care are they seeking? Do they need to be out? Are they going to be outed? Are they seeing a primary care physician and it's relevant for them to be out because they maybe need a pap smear or a prostate check? Or are they going to see maybe a chiropractor or a physical therapist, and perhaps it's not relevant for that provider to know about their trans identity? So then we have to think about, well, okay, what degree are they out? And then what is the provider's knowledge and openness to talk about that and to work with that individual? Trans individuals are often most scared about this aspect because when providers are not knowledgeable and not open to working with them, they often shut down and refer them out and say that they're not a trans specialist. Well, to let the cat out of the bag, there's no such thing as a trans specialist. All of us can be a trans specialist if we just study up and know a little bit about this population and are open to learning from them. We can't necessarily allow them to be our educator all around, but we can listen to them and listen to what they need. Because the wellness exams, those general pap smears, the prostate checks, the breast exams, if someone doesn't know how to do that, that can be a really awkward predicament for a trans individual to be in if they are very male appearing and have to go into an OBGYN's office to get a routine pap smear. So there are a lot of barriers that exist that we can be conscious of to reduce as much as possible. When we think about transition-related care, there are many barriers such as, well, what about therapy, mental health services? Is gender dysphoria a covered diagnostic category? Does someone know about gender dysphoria? Do they know how to work with that? One interesting thing and kind of devastating but understandable thing is that in many states, trans individuals are required to go to therapy to get a diagnosis of gender dysphoria from a mental health professional and get a letter written from their mental health professional in order to pursue any degree of physical transition, to get hormone replacement therapy, the HRT, to get hormone blockers as kiddos, and to get gender confirmation surgery, the GCS, in order to affirm themselves in their own bodies. So there are so many barriers and hoops that these individuals have to talk to that often make them feel aversive to it in the first place, because the outcome is if people aren't aware of how to treat trans individuals, one outcome is that they might just be outright denied care. Hey, we're not a trans clinic, we're not trans specialists, so you know what, we can't see you here. They might try to refer out to a trans specialist, which then just kind of puts a trans individual on a wild goose chase to find someone who's able to work with them. Many providers, unfortunately, downright refuse care. They say, you know what, I'm actually not comfortable with this. This kind of freaks me out. You are an anomaly to me. I work with just men and women. So they might refuse them care and say, good luck. Or trans individuals might have gone through that wild goose chase enough throughout their life that rather than even going through that headache, they take it upon themselves to postpone their own care and don't seek out adequate medical care and medical care when they need it, or health care when they need it. So you can imagine how the health disparities grow because of these many outcomes. The one thing that I love about the survey that I mentioned is that there are so many quotes throughout to bring life to this, to give voice to the trans individuals. So one is, my state Medicaid did not cover hormones or surgeries. With very limited income, it is difficult to afford the treatment I need, and I'll most likely never be able to have surgeries. The weight behind that is such a common sentiment and mood that many trans individuals feel chronically. Conversely, we see, a year ago, I felt hopeless and had daily suicidal thoughts, but today I've got a plan for the future and haven't had serious suicidal thoughts in months. I firmly believe this is because of my transition. I feel so much more comfortable and happy than I've ever been. I like the light at the end of the tunnel there because it's so heavy in the beginning with the common experience of chronic suicidal thoughts. But they mention that by being able to transition and become comfortable within themselves, that alleviated. So we need to be there to create these avenues to help people alleviate all those stressors, anxieties, and worries that they have by not feeling comfortable within their own skin. When we think about overall health and psychological distress, this relates to the other slide of, we have to think about the quality of care, continuity of care, and appropriate self-care education. If the quality of care is diminished because someone doesn't know what to do to work with a trans individual. Therefore, they refer them out consistently. That means the continuity of their care is so sporadic and discontinuous that no one really has any consistent idea of what the care plan is for this individual. They're not getting appropriate self care education on how to take care of their basic biological needs, let alone their transition related needs, how to appropriately inject themselves with testosterone or estrogen, or so on and so forth. So their health is diminishing overall because of this discontinuity in the quality and continuity of their care. So, of course, psychological distress is going to come in. Their dysphoria is going to be skyrocketed because they're not being able to feel complete within their body. Their stress and anxiety is going to be through the roof as well because they're having to anticipate stressful situations at any given moment in their life, out in and out of the healthcare realm. So their anxiety is going to be chronic. They might fall into a stent of depression, whether it's chronic or not, and they're going to be fearful of what does the future look like for them. So the outcome of this is that we're going to see increased rates of HIV/AIDS. We're going to see increased use in substances or other unhelpful coping mechanisms. We're going to see a spike in severe psychological distress, more self-harm behavior, suicidal ideation, and unfortunately suicidal attempts. It is very devastating to know that the statistics around suicidal attempts and suicidal completions are among the highest within the trans community compared to many other minority communities. Although the statistics are somewhat varied depending on what population they're able to actually reach out to, generally speaking, over 40% of individuals have attempted suicide at some point in their life that identify as trans. And that is an absolutely devastating statistic and something that we need to be aware of in order to diminish, to improve the health care for these individuals. So another quote is, I was told that I was deceiving my doctor and interfering with my care by not disclosing of identifying as transgender right away, despite my presenting concern being vertigo. So this is such a common experience as well. Individuals going in for just routine care and things, being told that they are pretenders, deceivers, liars, because they didn't tell that provider that they are trans right off the bat. This quote strikes a chord with me and resonates with me so strongly because this quote is from me. This was an experience that I had where I went in to address some vertigo concerns that I was having, and I was extremely transparent on all my paperwork, like I often am, by disclosing of the surgeries that I've been very fortunate to be able to have and afford and have support from my family for, that I've had hormone replacement therapy for years on years, and feel confident as a man. And I don't always think to disclose my trans identity as the first thing, just as much as I don't disclose of my athlete identity or the fact that I have, a wife and 3 siblings and so on. We don't always just word vomit everything about ourselves if it's not relevant. And so oftentimes us as trans individuals are called liars, deceivers, and so on. And so you can see where we would avoid situations such as healthcare realms and so on. I share my experience to really bring life again to this training, to say that not only is this an experience of the trans community at large and people that we might presume or assume to be trans, but often people that appear like me, that maybe you wouldn't assume I'm trans. Just as a reminder, and I share this as a reminder, that we never know people's background. We never know their history. And so we need to approach every single patient we work with respect, affirmation, and make it a safe place for them to share things with us. We can't approach them with harshness and with confrontation because that's going to increase the health disparities that we're seeing. Because there's this vicious cycle that happens where there's a significant amount of prejudice and discrimination that exists in the world, unfortunately, especially towards trans individuals, something that I have called historically anti-transgender prejudice. So this prejudice and discrimination exists, which is leading trans individuals to avoid a lot of places, including healthcare. They're avoiding socialization. They're avoiding taking care of their minds and bodies in mental health care and physical health care. They're avoiding maybe going to the workplace and getting a job and so on. And that avoidance is, of course, leading to more health and physical and mental health disparities. And when there's physical and mental health disparities within the community, that's leading to more prejudice and discrimination. There are statements like, man, the trans community is just rampant with sexually transmitted diseases. They are just rampant with mental health disorders and so on. There's all these stereotypes that exist within the community, some of which are partially true. But when we look more closely at this vicious cycle, we realize that it's not true because the community is not taking care of themselves or are just, out there and not trying to do anything to co- contribute to the community in a positive way. Is because the community isn't necessarily recognizing and taking care of them. So we need to do something. We need to intervene in this vicious cycle, break the cycle at some point in order to create a new, more healthy cycle for these individuals, to reduce the prejudice and discrimination, invite people and as opposed to making them feel like they need to avoid, and decrease those health disparities. And I truly believe that you, as a viewer, have the ability to single-handedly change the life of a trans individual, no matter who you are, no matter what healthcare profession you are in or training to be. Whether you are a physician, a mental health provider, an x-ray technician, no matter what you are doing, by asking questions of what is the sex assigned at birth, what is your current gender identification, and so on, that can be a world of a difference for a trans individual. So say you're an x-ray technician, for an example, and you ask someone that looks like me, what was the sex you were assigned at birth? What is your current gender identity? Is there any chance that you could be pregnant? And maybe using and asking that question across the board to anyone, no matter what you know about them, to just do a very thorough screener. Some people might be thrown off. Well, no, I could never be pregnant. But for someone who maybe is a trans man that hasn't had surgery and could be, that could be such a life-saving experience for that individual and perhaps the fetus that they're carrying. So those are things to just think about. And I encourage you to think, where does your profession fit in here, and what are unique questions that you could be asking? So here are the recommendations to overcome these barriers and how to create a welcoming environment, to make it feel more like the rolling sand dunes as opposed to the striking mountains, so that we can, as trans individuals, can feel like we can reach the top and overcome them, and so that they don't feel so daunting. That's my cheesy segue into overcoming the barriers. I would take questions again, write them down, email them to me if they come up throughout this. But I'll share this quote with you. Healthcare providers know 90 to 100% of what they need to know for the healthcare of trans folks. This is a colleague of mine that I greatly adore because she many, many times has said, trans care is not rocket science. We all can do it, and we all have the capacity to do it. We know a significant amount of what we need to know to work with these folks, so we need to work with them. So Joey Banks has said this multiple times, and I couldn't agree more. I think we all have the capacity to be trans affirmative providers by making simple changes in our approach to care for these individuals. So here's individual strategies, and then I'll break into organizational strategies. First, avoid assumptions. We've all heard the phrase that assuming makes an ass out of you and me, and it certainly does. So when we avoid assumptions, we are in turn creating a welcoming environment, allowing people to inform us on information about them. So don't assume gender or sexuality based on looks or sounds. Simple changes. Instead of saying, "How may I help you, sir?" just say, "How may I help you?" We don't need to have that formalized gendered language in order to be a good healthcare agency. We can just drop that and make it more universal. On the other side of the spectrum, we don't need to be waving pride flags and, jumping up and down when we think or presume someone might identify within the LGBT community, the lesbian, gay, bisexual, and transgender community. So you don't need to say, "We're an LGBT-friendly clinic, like, come see us." If someone looks like they might be hesitant, you can just remind them that we are a welcoming clinic for any and all people. You can make it, again, more universal to let them know, hey, we see you, we hear you, and we're going to accommodate you in whatever needs that you have. Don't assume how a person describes himself or their partners. These are, again, simple changes. Instead of having leading assumptions about a person's name or pronouns, instead of saying Sarah's here for her appointment, for perhaps MAs or nurses or administrative staff that might be working, you could just say your patient is ready to be seen, or hey, your patient's ready. Instead of asking patients things like, do you have a husband, and assuming things about their relationship status, asking things like, do you have a partner, or tell me about your support network, tell me about who you trust helping you take care of your healthcare needs, different things like that. Practice what works for you and just drop that assumptive language. Again, don't assume background information. What are your mother's and father's names? Know that for the trans community, among a great deal of the gender and sexual minority community, a lot of times they are kicked out of their family, unfortunately. So, therefore, asking about who takes care of you, what are your parents or guardians' names, might be a more affirmative approach because many trans individuals have what is called a chosen family, and that's family that has kind of taken over for helping them out throughout life and taken over their care that might not be their biological family. And just never, ever, ever say, like, gosh, you shouldn't have transitioned. You would have been such a cute little boy or girl. Of course, that person doesn't want to hear that, and they don't want to think about what they were born into because likely they never identified that way. And also avoid things like, man, you transitioned well, or you turned out to be an attractive male or female. Um, you would never say that to anyone else, so don't say that to trans individuals. Thinking about body language. This is a simple one that we're taught in school, in elementary school, to, give appropriate eye contact. Make sure that you're listening actively. Keep an open body language. These are just simple reminders for us all. And I remind this because oftentimes when we feel uncomfortable in situations, we tend to shut down and close and tighten in our body. We kind of like cross our arms and look uncomfortable. And we often do that with trans individuals in the room if we don't know their gender identity and how they would describe themselves. So keep an open body posture that'll communicate that you're open-minded and will allow that trans individual more quickly, perhaps, to disclose of their identity if they feel they need to. So other individual strategies addressing patients, know that the driver's license that they have may or may not match their birth certificate, may or may not match how they appear in person with you, and may or may not match the records that you have access to. So those are things to be extremely cognizant of because for trans individuals, it often is an uphill battle to change legal documents. Going back to the other barriers that I mentioned of needing the letter from a therapist in order to get surgery or hormones, will oftentimes state require you to have certain amount of years on hormones or certain surgeries completed before you can change your legal sex marker if you want to. So that can lead to this exaggerated delay in when people can not only affirm their body physically, but affirm it legally as well. So know that all those documents may not be consistent. So you may need to come up with unique ways to ask how they identify if the records don't match how they're appearing in person. So think about pronouns. Go back to basic grammatical lessons and remind yourself that she, her, he, him, his, they, them, theirs are appropriate pronouns to use if that person identifies with them, or maybe use gender-neutral pronouns like ze, them, zers. The number one thing I'm told is that I can't pull myself to use they, them, theirs. That's a plural pronoun, and I can't use that for a singular person. Well, the Webster's Dictionary a few years back celebrated they as a singular pronoun. So, in fact, if you're grammatically inclined like me, it is actually appropriate to use they as a singular pronoun and to write that in a chart note if you're talking about them. And that is a really good pronoun to default to, or just using the individual's preferred name over and over again if you're having trouble affirming them with the pronouns that they identify with. So if you're unsure about a patient's name or pronoun, say, what name do you prefer? What pronouns do you identify? What are your accurate pronouns? You can model this by saying, hey, I'm here to work with you. My name is Oak. I identify or I use pronouns he, him, his, or maybe on your name tags at work, you can put preferred pronouns. A lot of people put them on their email signature. Different ways that you can model it to disclose things to your patients that are appropriate for maybe you to disclose, that'll feel them welcome to disclose that to you. If the patient's name or gender that they identify with and that they're communicating to you doesn't match the insurance or medical records, find unique ways to ask them. Could your chart or insurance be under a different name? What name or gender or sex does your insurance have you listed as? Those are different questions to ask to let them know that you're trying to work with them, not against them. And if you make a mistake, don't sweat it. Just take note and correct it the next time. Don't make a big deal. Think about how your EHR is set up, your electronic health record. Find ways to make it more affirmative. Sometimes partnering with the IT department can be some of the great interdisciplinary collaborations that you can do to say, hey, I noticed on our EHR there is no place to put in preferred name, to put in accurate pronouns. Is there any way that we can do that? And likely they might be able to say, yeah, we just don't have that function turned on, or yeah, let me get on that. I know IT often is bogged down with a lot of different things, but especially where we're at now when they have some time to maybe make some changes before we all get back into our normal day-to-day routines, this might be a great time for them to change that. So this is what an EHR I use look like, where we were able to put in affirmative things for our patients and update them as relevant, because as I mentioned before, we don't just want to change this once. This is a thing that we want to ask relatively frequently, especially if we're working with a trans individual that is in the middle of their transition and maybe isn't comfortable changing their name or their pronouns yet. So some other individual strategies are thinking about appropriate care and anatomy descriptors, especially for my physical health folks that might be listening, asking what is your current anatomy before you require them to derobe and put on a, those gowns that are in scarcity right now, but just asking questions like, what's your current anatomy? When I'm asked that question, I say I have male anatomy, but I don't have a prostate. Well, that already makes my healthcare expedited because we have a really clear picture as opposed to my provider assuming things about me. Have you had any surgeries? What did your surgeries look like? Ask to the degree of appropriateness. Don't ask for your curiosity, and let them know why you're asking. I'm asking because I want to make sure that we're doing the regular health screeners or appropriate health screeners for you at your age. And then asking if someone maybe hasn't had surgery and doing a pap smear, a prostate check, a colonoscopy or something like that. Asking them, how would you like me to address your anatomy? If someone is, let's say, a trans male, meaning that they are assigned female at birth but currently identify as male, but haven't had surgery, meaning that they likely have a vagina, ovaries, uterus, fallopian tubes, and so on, so they need maybe a pap smear to be proactively taking care of themselves. But they say that they refer to their anatomy as their penis, or as their junk, or as their bits, or as their parts. It is not going to change your medical approach or your healthcare approach to refer to it that way as well when you're doing an exam with them. That is going to make them the most comfortable as possible. Let me repeat that. It is not going to change your medical approach by calling it that while you're working with them, affirming and using the language that they use to refer to their own anatomy while you are working with them. And even perhaps writing that in notes to communicate to the other folks that they might see if it's a shared medical record or if their records need to be released. That can help expedite the process if they move to a new provider at some point in time. It's not going to change your approach. It's only going to build your rapport that much stronger. And then asking, is there anything else I can do to make you feel comfortable? Always check in with them to make sure that they're comfortable, as you would with any patient. But just be even more hypervigilant with the trans community, knowing what I've shared with you about the historical prejudice and discrimination that they have faced in the healthcare realm. And then, of course, ask, and apologize. Respect, empathy, and a healthy amount of curiosity goes a long way in affirming these individuals. So ask for clarifications, apologize for mistakes, and move on. You will build rapport with this community very quickly if you are working as affirmatively as you can. This population has proven to be quite resilient, so it's okay if you make a mistake. And then finally, organizational strategies. These are kind of the heavy hitters, and then I encourage you to think about what are additional ways that you as an individual in your agency can implement these strategies and then go beyond that. And if you think of some that are outside of what I'm sharing, share with me, please, because I would love to include more and more strategies in future trainings. So gender-neutral bathrooms. Oftentimes, a lot of offices have single stall bathrooms, but yet they have the gendered or sex labels of male and female, despite them being just a single stall. So advocate for adding something like this, an all-gender restroom. Transform those single stall bathrooms into all gender restrooms, and importantly, know where they're located. Sometimes, for whatever reason, these single stall bathrooms are tucked away in the most random corners of places, so know where they're located. Have the administrative staff in the building also know where they're located, so that when someone asks where the restroom is, you could say, there's multiple stall bathrooms around the corner, but if you're looking for a single stall, it's located over here. Or have a map somewhere um, on a bulletin board or something to show where those bathrooms are located, so you don't need to out anyone. You could share that information with anyone. Here's a multiple stall bathroom, here's a single stall. Make sure that your paperwork is inclusive. Utilize that two-step method that I asked in the paperwork. Ask about sex assigned at birth and current gender identification, among other categories that are relevant for your particular health agency. Double check that. If it doesn't ask those questions, if it doesn't seem inclusive, if it seems really jarring, outdated language, now's the time to make a change. And that goes with organized EHRs. If you're not using hard copy paperwork and that's all programmed into EHRs, check on that as well, making sure that it's affirmative language and making sure that there's a common approach to asking these questions across all healthcare providers in that agency so that everyone is documenting things in their notes the same way. So, for example, if I'm working with a trans individual, I'm using they, them, their because that's a pronoun that they identified to me that they feel comfortable with. That if I'm referring them to another person, that they also are using that in their note. So, making a system with your colleagues to make sure that there's consistency in these notes so that everyone's approaching that person the same way so that that person doesn't have to rehash their story, out themselves time and time again, and that if their notes ever get released to other folks for multiple reasons, that they also are on the same page. So make sure they're organized. Check in with a non-discrimination policy. See if it protects against sex, gender, sexual orientation, and so on and so forth. If it doesn't, approach your the higher ups in your agency and say, why not? Why does it not protect that? Because the non-discrimination policy is protecting the patients as well as you. Think about the external environment. Is it friendly? Is it welcoming? Add some LGBT office decor and handouts. Things like the magazines that you have in the waiting room. Are they representing diverse gender identifications? Do you have literature for other trainees like myself who might go into an agency that can say, wow, these people are really studied up on trans care because they have that adult trans care book on their shelf, which I'll share that I was very, very fortunate to co-author a chapter in that book on creating a welcoming environment for trans individuals. So I encourage anyone to purchase that book. I think it's wonderfully written and it's a collaborative effort from many trans experts throughout the US and the world, really. It's written predominantly for mental health providers, but I think it's helpful for any healthcare provider, period. So check it out. Put pride flags somewhere, subtly throughout, and just make sure that there's diverse representations throughout the agency. And continue to seek out safe zone type training. Continue to seek out trans affirmative care trainings, because this is not the end of the road. I've given you a lot of information. I know I talk a little fast because I get so passionate and excited about this, but this is a growing field of understanding, a growing field of how to be affirmative. So keep seeking it out. Whether it's quarterly, biannually, annually, make it a required training for any new hires. And know that on average, throughout my research, people get 1 hour or less of training on trans-specific care. So we need to change that as well as we need to change, of course, the healthcare approach for trans individuals. But we need to advocate for integration of this type of training as normative in the healthcare realm, in the workplace, but also in early education, in grad school, in undergrad. So how we can do that is by implementing some of these things that I've mentioned. So this is the homework I leave with you: is locate those gender neutral bathrooms, advocate for changing to them, add that affirmative decor to office work, review your paperwork for inclusivity, practice how you could ask questions and normalize discussing trans experiences, and normalize maybe asking these questions to your cisgender patients as well, so that they can begin to be cultured in talking about trans identities and questions, so that they can also be affirmative to maybe their colleagues. So I truly believe that interprofessional collaborations and welcoming environments are the key to the health and wellness of the trans community. So when we work together and we advocate for this population and advocate for changes in and out of our healthcare settings, we are going to make a change and we are going to make a better and safer place for the trans community. So find a way to make changes in your healthcare approach and in your healthcare agency to make it so that it is a more inclusive and safe place for these trans individuals. Last but not least, I leave you with, so once you are done listening to me, please exit out of just this video tab and return back to that original tab that came from the email, bringing you back to that Qualtrics survey to complete the post-training survey. Please, please, please complete that post-training survey because that is necessary for the completion of the research component of my dissertation, and that will be critical for us understanding how trainings like this do indeed impact the understanding of health care approaches for trans individuals. So I thank you in advance. If you, for whatever reason, lose access to the post-training survey and exited out of that tab, please email me at the email below. I greatly thank you for sitting with me and thinking about how you can make changes in your approach to care, what this means to you, and I hope that you find some solace and comfort in knowing that you can be a trans affirmative provider with some simple changes. So I leave you with my email. I leave you with some of my research, some other resources to check out if you would like to. And again, if you have any questions at all, please email me. I thank you so much, and I hope that you have a great day. Stay healthy, stay safe, stay active.